Good afternoon, everyone. Welcome back. To this Climb India Journal Club. This is an educational initiative which is being rolled out as a part of our Center for Advanced Research, looking at the impact of climate change and brain infections. And we have been running two flagship webinars. One is Let's Talk Brain Infections, so where we will have a webinar focused on a particular brain infection, and following which we'll also have a journal club, which will focus on how to appraise a particular evidence which is available in this field. And similarly, we have another flagship webinar, which is the Let's Talk Climate, which will focus on some aspect of climate, which will be discussed in depth by the experts. So it's my privilege and honor to have Dr. Vignesh Kumar, Professor and Head of Medicine Department, Unit 2 from Christian Medical College, Vellore, to chair this journal club this evening. So he's a part of the distinguished faculty contributing to clinical care, teaching, and research in internal medicine. And he's involved in active research, and he currently is heading the clinical epidemiology unit and conducting all journal critical appraisals, discussing on various tools, as well as guiding postgraduates and junior faculty in this field of clinical epidemiology. We are happy to have you, sir, to moderate this session. And the presenter will be Dr. Elvin Peter, who's Assistant Professor in the Department of General Medicine. And he will be talking today on the current evidence of what is available in dengue vaccines, and sir will help him to appraise the existing evidence for us to make a decision. So over to Dr. Elvin for the session.
So good afternoon, everyone. Thank you for that introduction. So today, as ma'am said, I'll be discussing on dengue vaccines. What is the current evidence, and how do we critically appraise the evidence to find out what is the current recommendation that are there in giving dengue vaccines. So I'll move on to a case scenario. So imagine I am a public health decision maker in the government of India, and I'm asked to review whether evidence on dengue vaccine efficacy and safety is sufficient for a national-wide rollout, given increasing the dengue burden. So what is the current epidemiology of dengue? So according to the WHO in 2024, there are 14.2 million dengue cases reported, including 7.5 million confirmed cases, with 52,000 severe cases and more than 10,000 deaths in 2024. So there have been various challenges in the field of development of vaccines against dengue. The main challenge is if you have a primary infection with the dengue serotypic virus, you have protection against only that serotype. So then when you get a second infection with another serotype, it is generally a severe infection. That is the main, because of an antibody-dependent enhancement. So because of this problem, there were challenges in development of the vaccines itself. So there were a lot of vaccines which have been tried. We have live attenuated vaccines. There have been inactivated vaccines. There are virus-like particles which has been tried. Subunit vaccines have been tried. Viral vector vaccines has been developing, and DNA-based vaccines are also been there. But even the challenges with the vaccines also, which we have today, is similar to what is happening about the dengue infection itself. That after a primary vaccination with the dengue vaccine, following which when they have a secondary infection, they seem to have a severe infection. So the current licensed vaccines which are available are the live attenuated vaccine, which is the CYD-TDV, which is the Dengue vaccine, and also the TAK-003 vaccine. These are the two vaccines which are being licensed. And then there is TV-003 vaccine and TV-005 vaccine and Butantan DV vaccines, which are in their phase 3 clinical trials. We have had inactivated vaccines, which is in their phase 2 clinical trials. There are DNA vaccines in phase 1 clinical trials. There are peptide-based vaccines, mRNA vaccines, and recombinant subunit vaccines. So going on to the main licensed dengue vaccine currently. So this CYD-TDV vaccine, the Dengue Vaxia one, came to license in 2015. And in WHO position paper in 2018, they actually recommended usage of this vaccine. So they've suggested 3 doses, which is to be used 6 months apart in individuals 9 to 45 years of age, and it was found to be efficacious and safe in seropositive individuals. However, like I said, the initial vaccination in a seronegative individual with a CYD TDV actually mimics a primary dengue infection, so that later if the person who was seronegative is vaccinated with the CYD TDV, the subsequent infections with other serotype of dengue virus leads to a severe infection. So they have actually recommended a pre-vaccination screening strategy before using this vaccine. So later on in 2022 to 2023, this TAK-003 vaccine had come, which was again recommended by the WHO in 2024 to be used in 6 to 60 years of age group people in areas with high dengue transmission intensity. So it was recommended to be used as a 2-dose schedule vaccine with an interval of 3 months. And even co-administration of the yellow fever and hepatitis A vaccines has been recommended by the WHO. However, during that time, the main difference of TAK-003 vaccine with CYD-TDV is both a live attenuated vaccine. However, this TAK-003 vaccine was also found to be effective in seronegative individual. That means if a patient did not have a previous infection with dengue, even in those patients, this TAK-003 was actually found to be effective. However, they recommend that it is contraindicated in pregnant lactating women, HIV-infected individuals, chemotherapy receiving patient, and patient receiving high-dose glucocorticoids. So going back to my clinical scenario that I looked at, if these vaccines can actually be rolled out in the national immunization program, and what is the current evidence for these vaccines, I had looked at the current evidence which is available, and this is the recent systematic review which had actually come in the Virology Journal in November 2025, in which they have actually looked at the dengue vaccine effectiveness and safety by doing a systematic analysis of recent clinical trial data. So I've used a checklist called as an AMSTA checklist to critically appraise the systematic review. So there are a lot of checklists available. So this was the one which was easily explainable one. That's why I've used the AMSTA checklist. So going on to the checklist for critical appraisal. So the first question actually talks about the research question and the inclusion criteria for the review include the competence of PICO. So the population that they have looked at in the systematic review in the included studies are healthy individuals of all age group, that is both pediatric and adult age groups. The intervention which was found in most of the clinical trials were the dengue vaccines, which included the TAK-003 vaccine, CYD-TDV vaccine, TV003, TV005 vaccine, and the Butantan DV vaccine. And most of the studies had comparator as a placebo. And outcomes which most of the studies have looked at is vaccine efficacy, immunogenicity, and safety. So the time frame for follow-up was, it ranged from 4 months to a maximum of 4.5 years. So one of the TAK-003 study which came out recently was the 4.5-year follow-up study which was there. Now, a second question is, did the report of the review contain an explicit statement that the review methods were established prior to the conduct of the review, and did the report justify any significant deviations from the protocol? So this question mainly talks about whether they had actually registered the study, and was there a clearly defined study protocol which was there before the start of the study. So when I looked at the supplementary appendix and the main study in the article, there was no protocol which was accessible for this systematic review, and there was no registration number which was available. So this is one of the major requirement that has to be there for systematic reviews when they register. Actually. So this was not found in the article. The third question is, did the review authors explain the selection of the study designs for inclusion in the systematic review? So they have included RCTs, which were randomized control trials from the last 5 years. So which are most recent RCTs from 2020 to 2025. So in which they included phase 1, 2, 3 clinical trials. And however, they've mentioned that they've excluded review articles, conference publications, systematic reviews, and studies, including concurrent infections. So like we all know, RCTs comprise one of the major evidence for this vaccines. And the WHO, the recommendation also came out in 2024. So probably that was the reason that they had looked only at RCTs for the last 5 years actually. So this was probably justified by using only RCTs in the systematic review. Now, fourth question was, did the review authors use a comprehensive literature search strategy? So this question, to say yes, they should have at least searched 2 databases. So they've actually searched PubMed, Cochrane, and Google Scholar, which they had mentioned in the article. However, few things which they've not done was they've not had a proper search strategy, or their search strategy actually has not published in the article. And whatever the keywords that they've actually used to search for these clinical trials was not mentioned in the article. And another thing was they have restricted the search for only for the past 5 years, which was from 2020 to 2025. They could have probably included the studies which were there, which was published even previously as well. Other thing was they have used only English language trials which were published. So there was a language restriction which they had used while searching for these clinical trials. And some things that which I thought that they had not searched was some bibliographic databases like Embase and Scopus. Even though they are paid, that was not searched. Citation databases like Web of Science and US Clinical Trial Registry, WHO Clinical Trial Registry, and Clinical Trial Registry of India also was not searched for ongoing unpublished RCTs. And they have not contacted any experts in the field of dengue vaccines. And they've also not searched any gray literature, which includes conference abstracts, unpublished reports, and regulatory reports. So these was one area, some areas which they had actually not searched while doing the systematic review. However, they actually searched 3 major databases, which is the PubMed, Cochrane, and Google Scholar. Now, the 5th question is, did the review authors perform study selection in duplicate? So when they do a systematic review, there should be 2 reviewers or 3 reviewers that each of them has to see each of the study, and they should agree that this study can be selected and it is an eligible study to be used in the systematic review. So that they have actually not done. So here I've given the Prisma flow diagram of how they had actually identified studies. So initially they've searched these databases, and then they've, after the first screening, they've just mentioned that they've excluded studies unrelated to dengue and those examining co-infections. And then they've screened around 108 studies, out of which again they've removed duplicates from different databases, around 41. And then around 67 studies were there after second screening. So this duplicate removal, how they have done, they had not really mentioned in the article. And after third screening also, they have mentioned they have excluded studies after assessing the full text. And finally, they included 14 studies in the systematic review. So this duplicate removal, how did they do this process was not clearly mentioned in the article. 6th question is, did the review authors perform data extraction in duplicate? So this again, similar to the previous question, that when they actually extract the data, that also has to be done in duplicate, that 2 people have to review it and then extract the data. So this was also not clearly mentioned in the article, that how did they do this. So that was also a no for this question as well. 8th question is, did the review authors describe the included studies in adequate detail? So this they have done, that they have actually given a summary of all clinical trials which are actually included in this systematic review. So initially there are 5 studies which are actually done on TAK 003. This is the major trial which was done, which was published in 2023, in which they have looked at the TAK 003 vaccine actually. This was done in mostly in countries like Brazil, Colombia, Dominican Republic, and Asian countries, Sri Lanka was included. And other trials which had looked at TAK 003, they had included 5 trials, and they have given in detail that which were the group of people they have included, what was the study period, and what is the vaccine efficacy safety, what is the vaccine schedule, and what is the conclusion of each of the studies. So they've described in great detail that. So this is the list of the trials which they've actually looked at for the CYD TDV, in which they have included 3 trials. One study was from Brazil, one was from southern Brazil, and other one from Latin America. Then these are the studies which they've included on the vaccine TV003 and TV005. So one study was done in Bangladesh, and other studies was done in US. And one more other study was there, which they've not mentioned the site, but they've again mentioned in detail of what is the details of each of these study. And this is the study trials which was done for Butantan DV vaccine and dengue vaccine. These studies were also predominantly done in Brazil. So they have included the details of each of the studies in great detail. Now, the next question is, did the review authors use a satisfactory technique for assessing the risk of bias in the individual studies that were included in the review? So assessing the risk of bias before, while you are incorporating a study into a systematic review is also an important process, because we need to identify what is the quality of studies which are actually included in the systematic review, so that if the quality of the studies is actually poor enough, then the outcome that you will get is also going to be a poor outcome, or you can't really trust the results of the systematic review. So this risk of bias, they've actually not mentioned how they have done this risk of bias, and they have actually not used any tools for assessing the risk of bias. What they had mentioned in the article is what they have done a sensitivity analysis after including the studies, and that's how they have excluded studies at high risk of bias. So they probably included some studies and done a sensitivity analysis and found out what is the risk, and then they would have done. So they have not clearly mentioned. This is the only line which is mentioned in the articles, that how they assess the risk of bias by doing a sensitivity analysis. Ideally, they should have given a risk of bias diagram and what tool they've used, so that we can also see what is the risk of bias and in which domain was the main risk of bias was there, so that we can also assess what is the quality of the included studies were. So this was not mentioned in the original article. Now, the 10th question was, did the review authors report on the sources of funding for the studies included in the review? So this was sources of funding for the individual studies. So that they have not reported what are the sources of funding for the individual studies. So this was mainly for any institutional sponsored studies and all that, whether that could have biased the outcomes that came out of these studies. So they had not looked for this information also, and they've not mentioned any of this in the original article. Now, 11th question is, if a meta-analysis was performed, did the review authors use appropriate methods for statistical combination of results? So they had actually done a meta-analysis, and they had mentioned that all the statistical analysis were performed using the R software. So this is again a software which can be used, which has been used by epidemiologists for doing this meta-analysis. So it is a good software which can be used, and using this, they have actually looked at and done most of the statistical analysis. They have done forest and funnel plotting, subgroup sensitivity analysis, and bias diagnostic using this software. And heterogeneity they had quantified using the I-square statistics and the Cochrane's Q test. So they have done a meta-analysis and they have used the software. So that is a yes for this question as well. Now, the 12th question is, if a meta-analysis was performed, did the review authors assess the potential impact of risk of bias in the individual studies on the results of the meta-analysis or other evidence synthesis? So like I had mentioned, the risk of bias of the individual studies was not assessed by them, and they have only done a sensitivity analysis which excluded studies with high risk of bias. So this was not done. Again, did the review authors account for the risk of bias in the individual studies when interpreting or discussing the results of the review? So even while including or analyzing, and when they are discussing the result, they should have discussed about the risk of bias. Again, this was also a no for this question. 14th question, did the review authors provide a satisfactory explanation for and discussion of any heterogeneity observed in the results of the review? So I'll move on to the funnel plot, the forest plot after this, that in that they had actually put a high heterogeneity of the included studies in vaccine efficacy and immunogenicity. However, they did not discuss the possible reasons for heterogeneity. And a heterogeneous study, which is if there is significant heterogeneity, it will actually impact, it will have impact on the results as well. So they have not discussed what is the impact of this heterogeneity on the results of the systematic review. Sorry for the diagram, which is very blurred, but this was the forest plot which I got from the original article. This was the maximum resolution which I could get. The forest plot which I published in the original article. So looking at it, I will tell the first one is the TAK003 forest plot which they have done. And the second one is the CYD TDV forest plot. And the third one is for the TV003, TV005 vaccine. So in the TAK003 vaccine, they have looked at the vaccine efficacy, immunogenicity, and safety. And in the vaccine efficacy, when they had looked at, so I had actually written in the next slide, what is vaccine efficacy formula? So to calculate the vaccine efficacy, you have to look at the attack rate. So attack rate of dengue in the unvaccinated minus attack rate in the vaccinated divided by attack rate in the unvaccinated into 100 will give you the vaccine efficacy. So here in the randomized control trial, you're getting a relative risk. So you can also calculate it by vaccine efficacy by 1 minus relative risk into 100. So this is how they have actually calculated the vaccine efficacy in this systematic review and in the included studies actually. So immunogenicity is actually how much is the antibody rise in titers rise post giving a vaccine. So it can be assessed either by a GMT, which is a geometric mean of antibody titers in a group, or also by the seroconversion percentage. That means out of the total vaccinated individuals, how many of the individuals have a significant rise in the antibody titers after vaccination. So that percentage can also be used for calculating the immunogenicity. So in the forest plot, the vaccine efficacy which they have got for TAK-003 vaccine was 85%. So here the relative risk is 0.15. So calculating the vaccine efficacy, you get an 85% vaccine efficacy. And the confidence interval actually range from 0.07 to 0.33, which is, it can actually range from 93% vaccine efficacy to 67% vaccine efficacy. So it is highly efficacious vaccine according to the systematic review. Now again, other vaccine, which is the CYD TDV vaccine, the vaccine efficacy which they've got to 66%, which was lesser than the TK003 vaccine. And the TV003, TV005 vaccine, the vaccine efficacy was 98%. However, this vaccine, only 2 studies are actually included for calculating the vaccine efficacy, and they got a 98% vaccine efficacy for this TV003-005 vaccine. Now, vaccine immunogenicity, they actually looked at only in TAK-003 vaccine, and then they've looked at the how much the antibody titers have actually gone up, and then the immunogenicity they've got is 4.09, which range from 2.09 to 7.85. So a person who is vaccinated with the TAK-003 vaccine had a 4.9 times rise in antibody titers post-vaccination, which can actually range from around 2 to 8, which was again showing a good immunogenicity post-vaccination with the TAK-003 vaccine. Now, going on to the vaccine safety, they have reported in all the vaccines which they have included in the forest plot. The vaccine safety was actually 0.85. That means in most of the trials, like I mentioned, they have compared the vaccine with the placebo. So they have actually said that the vaccine was even safer than the placebo injection, that adverse events are actually more in the placebo group. So there were 15% reduced adverse events in the TAK-003 vaccinated patients. And even in the CYD TDV also had a 7% reduction in the adverse events. So it was safer. And even TV003, TV005 vaccine, the vaccine safety was 1.37. So it had slightly increased adverse events post-vaccination compared to the placebo. So the overall results, all the vaccines actually are proven to be very efficacious according to the forest plot actually. Now, if they perform the qualitative synthesis, did the review authors carry out an adequate investigation of publication bias and discuss its likely impact on the results of the review? So they should have discussed how many studies have actually been published, and they should have put a funnel plot so that we can actually assess that whether they've included all the studies which had actually come out. So they did not discuss this publication bias in their article, and there were no funnel plots also which were mentioned in the article. Now, did the review authors report any potential sources of conflict of interest, including any funding they received for conducting the review? So funding, they had mentioned at the end of the article that financial support is not applicable for the preparation of the systematic review. And they declared no competing interests were also there. So after this concludes the critical appraisal of the systematic review which was done. So like I mentioned, there are a lot of areas where the risk of bias was not assessed, and there were areas where things had to be reported, like publication bias was not there. And even in the forest plot also, even though they had mentioned, it was not very clear of what the data was. So finally, what I feel after critically appraising this systematic review is that Although vaccine efficacy appears promising, because most of the vaccine which I discussed is actually showing a very good efficacy. However, there is significant methodological limitations and potential risk of bias across the studies which has been included in the systematic review. So this can actually affect the reliability of these estimates which they are actually presented. And this results cannot be used in decision making directly. And we definitely need methodologically sound systematic reviews to finally make a decision on whether these vaccines has to be rolled out in the national program or not. Now, this systematic review, after this, we did look at literature, and there are few studies which are still being done and published, which is not included in this systematic review. So I'll move on to 2-3 of those studies. One study is its phase 1 randomized placebo-controlled trial, in which they evaluated the efficacy and safety of a live attenuated tetravalent dengue vaccine, KD382, in flavivirus antibody naive healthy adults. And this was a study which was actually done in Japan. So this was a phase 1 trial. So they had looked at mainly safety and immunogenicity as well. So this is published in the Vaccine Journal in 2025. The population of the study was healthy adults of 18 to 65 years of age group, and they did not have a previous exposure to dengue. And intervention they have used is this KD382 vaccine, and they've used intervention as a low dose of this vaccine, which is 1/100th of the standard dose. And control they've used as a standard dose of KD382 or placebo. And outcome, what they've looked at is a safety and immunogenicity at 3, 6, and 12 months. And the time of follow-up was a total of 1 year of follow-up they've done. Now, here, immunogenicity, how they've assessed it, they've actually done the geometrical mean titers of the antibodies, and they have also calculated the FRNT50. So FRNT50 is the serum dilution at which 50% of the viral foci are actually neutralized. So if they describe seronegativity, that means a person who did not have an immunity against dengue virus, or they did not have a previous vaccination or infection with the dengue virus. That is called seronegativity. So that they have defined as an FRNT50 value of less than 1:10, and seropositivity was defined as an FRNT50 value of more than 1:10. So I will not discuss it in great detail. However, I will go on to the salient points in assessing the validity of the study. So as it was a randomized control trial, they had done randomization in the study using an interactive voice web response system, in which they have divided the patients into 2 groups, low dose and standard dose. And each group, the participants were divided into 3:2:1 ratio, in which they either received a single dose of the vaccine, or they received 2 doses of the vaccine, or they received placebo. There were totally 2 groups. Each group had again 3 subgroup dosagings. That if they belong to the low dose group, then the single dose people received only 1 dose, and the second dose which they received was the placebo. And the 2-dose group received 2 doses of the low dose vaccine, and the placebo received 2 doses of the placebo. The same way in the standard dose group, either they received single dose of the standard dose and the second dose is placebo, and 2 doses would be 2 doses of the standard dose, and placebo will be 2 doses again. So everyone who is included received 2 doses of the vaccine. It was either a low dose vaccine with a placebo, or a standard dose vaccine with a placebo, or 2 doses of the low dose, 2 doses of the standard dose, or 2 doses of placebo. So allocation concealment they have done using an interactive web response system. And blinding, they had mentioned in the article that they've done double blinding, but they've not clearly mentioned who did they mean by this double blinding. So I assume that probably the patient and the investigators who are giving the vaccine were actually blinded. However, they have not mentioned an outcome assessor blinding. But here, probably one thing is immunogenicity might not have changed, even though even the outcome assessor was not blinded. But probably the safety, when they had assessed, it was required for the outcome assessor to be blinded. So that data was actually not mentioned in the article. And sample size, they mentioned that they have calculated the sample size. However, the data that they've given in the article regarding calculation sample size was slightly incomplete, so that we could not identify completely how they've done the sample size. And they've not done intention to treat analysis. They have done a per protocol analysis in this review. And the baseline characters of the study population, they've well matched. So these were patients who did not have a prior exposure to dengue. So this is the baseline characteristics of the study population. So they have said that the most of the patients were belonging to the age group of around 30 to 40 age group, and females were slightly higher to 60 to 80% compared to male population, and mostly whites were included, and there were no Asians, only 1 or 2 Asians which were actually included in the study. So not much Asians were in the study population. And they, even though they have said that they taken patients with a negative serological status of dengue, they could have included what is the baseline, what is the serological status, and they could have compared in the both the groups before giving. That value was also not mentioned. Now, this is the study consort diagram where they have actually screened 180 patients, and finally they enrolled and randomized 60 participants, out of which 30 went into the low dose arm and 30 went into the standard arm. And like I had mentioned, there were 3 sequences in each arm, in which first sequence receives only a single dose of the low dose, and second sequence received 2 doses, that is low dose, 2 doses of the low dose vaccine, and third sequence received only placebo. The same way in the standard dose also, there was single dose, 2 dose, and placebo which was given. So the first vaccine was given on day 1. After that, the second dosage of the vaccine for the 2 dose vaccine group, it was given on day 29, and then third, finally they had completed it on day 57. This is actually, they have taken this 28 days post 1 vaccination, because that is 4 weeks is the time at which maximum number of neutralizing antibodies actually develop in the serum. That's why they've taken this 28 days after each vaccine to assess the immunogenicity and safety. And they have actually followed up these patients for a period of 12 months to find out what is their safety and immunogenicity. So the loss to follow up was actually 10% in the low dose arm and 16% in the standard dose arm. So moving on to the results of the study. So they have looked at the seroconversion rate for all strains of dengue virus. So what they have found is that immunogenicity or seroconversion rate is actually 100% for all strains of dengue virus. So they have actually taken the serum of these patients, and they have inoculated with dengue virus different serotypic antigens, and they have found out whether they had seroconversion or not. So they've actually found out even if they have had a single dose of either the low dose or the standard dose, they had 100% seroconversion. So I'll just highlight one of this thing, the first line, where in the dengue 1 serotype, in the sequence 1, there were 13 people who are in the sequence 1, in which 13 people had a 100% seroconversion when they assessed at day 29. And in the sequence 2, even 8 people were there, and 8 people had 100% seroconversion. And pooled also, everyone had total seroconversion. Even in the standard group also, they had 100% seroconversion. So in each dengue virus serotypes, this is the initial one is at day 29, then they'd again assess at day 57, and then they'd assessed at 3 months, 6 months, and at 12 months. At every stage, they have actually found out that the titers, antibody titers, are actually present even at 12 months of follow-up, and it was 100% as well. Now, this is a graph in which they have looked at the geometrical mean titers of the antibodies. So the green one, or the one which is flat line, is actually the placebo, in which they did not have any seroconversion. And all the other low dose and standard dose had seroconversion rates. And even in the first assessment at day 28 itself, they've actually found out that there is significant rise in the antibody titers. So the 4 graphs represent different dengue virus serotypes. So there was no significant difference between low dose and standard dose. However, low dose are actually showing significant rise in titers similar to the standard dose. Now, as it is a phase 1 trial, we should look at the safety outcomes mainly. And subjects with local adverse events, because this is an injection which said given. So around 93% of the patients had at least a local adverse event which was there, probably an injection site reaction. And even in the low standard dose also, there was around 90 to 100% adverse events, I mean local reactions, which was actually found. The serious systemic adverse events, what they had mentioned is mainly blood and lymphatic system disorders or more, followed by infections and infestation they had, and nervous system disorders. These were the main safety concerns which they've actually noted post-vaccination with this KD382. So as I had mentioned, the Asians were not included in the studies, and the individuals were mostly 40 to 60 years of 40 to 30 to 40 years of age group. So the most of the dengue patients that we see are even younger patients, actually around maybe 10 to 30 years of age group, and maybe that might limit applicability of these results to our study, our local population. Now, this is another study in which they've looked at the safety and immunogenicity of tetravalent dengue vaccine. This is a CYD-TDV vaccine, which is a live attenuated vaccine, in which they've looked at the HIV positive adults in Brazil, aged 18 to 50 years. This was a phase 2 randomized control trial. So generally, the problem with vaccinating an HIV positive adult with a live attenuated vaccine is that there is risk of dengue infection in them, as well as a severe infection they can actually acquire. So this was one of the trials which was done in HIV seropositive adults. This is one of the trials which was actually done. And this was actually published in Human Vaccine and Immunotherapeutic Journal in 2025. So in this, they've looked at adults 18 to 50 years of age with HIV seropositive status and prior exposure to dengue infection. They've looked at patients with prior exposure because CYD-TDV vaccine can only be given in patients with the prior exposure to dengue infection, because if it is a seronegative individual, then they will have a serious dengue infection when they have a second infection with dengue. And most of all these patients which they have taken had a stable CD4 count of more than 350 and an HIV viral load of less than 50. So they were all patients who were stable. Because it was a live attenuated vaccine, they could not have used the patients who are actually having an active virological load and low CD4 counts. And the intervention was 3 subcutaneous injection of the CYD-TDV vaccine, which is given at day 0, 6 months, and 12 months. And control was placebo given at day 0, 6 months, and 12 months. And outcome they've looked at is safety and immunogenicity of the CYD-TDV vaccine. And the timing of follow-up was up to 18 months. And it was done in 4 sites of Brazil. So validity of the study, randomization they have done using an interactive web response system in a 2:1 ratio for vaccine versus placebo. And they have done allocation concealment. And blinding, again, they've said that they have blinded the investigator, participant, and the sponsor, but no detail about the outcome assessor blinding. And sample size, they've taken the sample size as 150. So what they had mentioned is they have not testing any hypothesis is what they had mentioned in the article. That's why they had their sample size is not powered to test any hypothesis. So how did they reach this 150 sample size? The details are actually not available. And due to COVID, they had only recruited 133 participants out of 150. And they have done intensity to treat analysis for safety outcomes and per protocol analysis for the immunogenicity. And the baseline characteristics were well matched. So this was the baseline characteristics of the study population. So they have randomized in a 2:1 ratio to vaccine and placebo group. In which when we look at the prior vaccination status, they had only looked at patients who had previous exposure to dengue actually. So prior to this first vaccination, around 92% in the vaccinated CYD-TDV group and 100% of the patients in the placebo group had immunity to dengue. Already they had a dengue infection actually. And what was the baseline CD4? Even though they had mentioned that most of them had CD4 count of more than 350, they had not put what is the baseline CD4 counts in the both the study population, the placebo and the vaccine group. And most of them were already immune to dengue because we can't give the CYD-TDV vaccine in a person who's a seronegative individual who did not have a previous dengue infection. That's why they were already having a high immunity to dengue before giving the vaccine. So out of 150, they had randomized only 133, out of which totally at the end of the follow-up, they had lost follow-up around 10% in the vaccine arm and around 2% in the control arm. So moving on to the results of the study regarding the safety outcome, the solicited reaction in the 28 days after any injection, there was around 64% in the CYD TDV group, and around 75% in the placebo group. This is mostly a reaction secondary to the injection, which happened within the 28 days. So they've said that most of the reaction to vaccination should have occurred within 28 days. And then the serious adverse reaction, which was attributed to the vaccine, was actually very less. There was only one death which they had reported in the vaccine arm, but this has actually happened later on during the 6-monthly follow-up. So they had this death also happened due to a cerebral hemorrhage in a patient. So they have said in the article that this cannot be attributed to the vaccine. However, they had put it as probably not related to the vaccine. However, there was only one death which was documented in the overall study population, which was in the vaccine group. Now they have looked at post-vaccine viremia. That means after giving an injection of this live attenuated, how many of them had a viremia which was detected after the injection? So around 14.1% of the patients after the first injection was found to have dengue viremia detected. And after the second injection, 2.4% of the patient had a dengue viremia detected in the vaccine group. And around 6.9% of the patients had a reduction in CD4 counts post injection with the CYD TDV vaccine. But they mentioned that none of them had a serious adverse events leading to mortality and all that. Now, vaccine efficacy, when they have looked at, they have actually looked at the geometric mean titers for the vaccine efficacy. So geometric mean titers, most of them initially had, before the injection itself, they had some antibody titers. All of them were immune to dengue. And then post vaccination, they have found that the antibody titers are actually gone up to 3-fold rise in the titers post the first injection itself. And post second and third injection, antibody titers remained stable actually. There was no further increase in the antibody titers, but the antibody titers remained stable even after third injection up to 1 year of follow-up actually. And this was actually found in all the serotypes of dengue vaccines. So again, this study was mainly done in HIV positive patients, and the center was in Brazil actually, and did not include any of the Asian population in the study. So again, extrapolating the results of this study to our local population might again be difficult. Now, this is one interesting study which I found that, as I had mentioned before, in the WHO recommendation which came out in 2024, they've said that the TAK-003 vaccine is recommended for usage, and there is recommendations of usage of it with yellow fever vaccine and hepatitis A vaccine. So this is another study which had recently come out, in which they've looked at the immunogenicity and safety of live attenuated tetravalent dengue vaccine co-administered with this 9-valent human papilloma virus vaccine. So why they'd done the study is because in both the age groups, so even in TAK-003 vaccine is recommended in patients of 6 to 16 years of age group, and even the 9-valent human papilloma virus vaccine is generally recommended in those age group, 9 to 15 years of age group populations, what they recommended. So to roll out as a program, it will be easier if they actually incorporate this TAK-003 vaccine with 9-valent human papilloma virus vaccine. That's why they've done this study. This was published in Vaccine Journal in 2025, and they have done this a non-inferiority trial, and they have looked at whether co-administration of HPV dengue vaccine is non-inferior to given HPV alone. So does giving dengue vaccine actually have any is safer, or whether it's non-inferior to giving just HPV alone. So population they've looked at is healthy adults of more than or equal to 9 to less than 15 years. An intervention they'd given us either a 9-valent HPV vaccine along with TAK-003 vaccine, and control was 9-valent HPV vaccine alone. And outcome they have looked at is the humoral immune response. And time of follow-up they've done is up to 12 months. So after 614 patients, they had randomized, and in the group 1 received both 9-valent HPV vaccine and TAK-003 vaccine, and the group 2 received only the 9-valent HPV vaccine. So at day 1 visit, they received either the intervention, which is both the vaccines, or the single vaccine, which is the HPV vaccine. And the second dose of this TAK-003 vaccine in the intervention arm is actually coming at 3 months. And then the 9-valent HPV vaccine next dose is actually coming at 6 months in both the arms. and then they had followed it up for a period of 1 year. So total 614 were randomized and 307 were assigned to both the groups. And they have done per protocol analysis in which 242 were included in the per protocol set in the intervention group and 235 in the control group. Baseline characteristics were also well matched in the study population. Most of the female males were equal actually, and the age of the study population were around 10 to 11 years. So going on to the results of the study, so they have actually defined the non-inferiority as whether the upper bound of the 95% confidence interval of the total IgG ratio. So this IgG ratio is the immune response towards HPV infection or HPV virus antibody, whether it's developed. Whether this IgG ratio is less than the margin of 1.5, then they had said that it is actually non-inferior. So the IgG ratio was calculated with the numerator with the 9-valent HPV alone and the denominator with the intervention group. So when they had actually looked at against all this serotypes of HPV, they had found that the co-administration of the combined vaccine, which is 9-valent HPV and the TAK-003, was found to be non-inferior. So they said that usage or co-administration of dengue vaccine with HPV did not actually reduce the immunogenicity of the HPV vaccine, and it was non-inferior to giving HPV vaccine alone. So there's something which could be considered in the future when we are actually introducing the dengue vaccine. But they have also looked at what is the dengue vaccine titers rise post giving this vaccine with HPV also. So the dengue neutralizing antibody titers also showed a significant response at 4 months. So TAK-003 was actually given at 0 and 3 months. So 1 month after the last dose of the vaccine, they have looked at what is the titers of the dengue vaccine. So in each of the serotypes, when they have looked at, they have found that the neutralizing antibodies showed a significant response after the vaccine at 3 months. And the HPV vaccine did not affect the antibody titers of the dengue vaccine, dengue neutralizing antibody titers. So adverse events also, they had not reported any severe adverse events in both the groups when they had given the vaccine. There are so many ongoing early phase clinical trials which are still registered and currently being done. So there is Britanton DV vaccine trial which is done in elderly population. So there is co-administration of dengue vaccine with chikungunya vaccine which is being studied now. Even 2 doses of tetravalent TDV vaccine in infants and toddlers. So there are multiple studies which are again in the pipeline which are still being done for assessing the safety and efficacy of dengue vaccine. So the recent, there is a core outcome measurement set for clinical trials in dengue, which this has come out in Lancet in 2025. In this Delphi consensus study, this was a first global effort for core outcome measurement in dengue clinical trials to harmonize outcome reporting. So most of the studies or trials that we have looked at till now, the outcomes are not really standardized. So because of that, in some they have used the geometrical mean titers, in some they have used the FRNT 50 for immunogenicity. Even the vaccine efficacy also, there are different things they've looked at. So there has to be a standardizing of this outcome reporting so that you can combine the results of all these trials. So that's why this global effort was there to standardize this outcome reporting. So most of this studies which I have looked at prior, they had looked at recurrence of dengue post-vaccination or the outcome measure to calculate the vaccine efficacy, and maximum duration of follow-up is also only 4.5 years. So what they have said in this core outcome measurement set is mortality, severity of dengue, and health-related quality of life should be the core outcomes for dengue clinical trials. And these things should be included in clinical trials which actually evaluates dengue vaccines or anything related to dengue. So that if these outcomes are there, it would be easier for them to combine these trials and probably form a systematic review and probably form a guideline based on these trials. And I personally feel it would also require a longer follow-up of these patients, because the maximum follow-up that we have is only 4.5 years in the study which I had mentioned before. So back to my case scenario, there is definitely a promising efficacy visible with good safety profile in most of the dengue vaccine, which I have discussed. However, with the current available evidence, I would not recommend rolling it out in the national immunization programs based on what evidence that is currently available. And there is definitely a future scope for methodologically sound systematic reviews before incorporation into clinical practice. Thank you. Thank you so much.
Thank you, Dr. Elvin, for a very comprehensive discussion of the evidence. It was really important because there's so much of data coming out slowly. So whether we need, because considering us being in the endemic country, review of this is very important for a policy decision. So may I invite some comments from Dr. Vignesh regarding the same.
Thank you. Thank you so much for inviting us for this August gathering. So I'd like to congratulate Dr. Elvin for having comprehensively summarized all the evidence that is currently available. So I also echo the same opinion as Dr. Elvin has mentioned, even though it appears pretty promising with pretty good looking efficacy rates, immunogenicity rates, but good synthesis of all the evidence is probably the need of the hour, and probably his presentation has thrown light into where some research interested, like-minded research people could channelize their interest, and probably we could, it's a area where people could venture and to do a good quality systematic review meta-analysis, which may actually be informing guideline as well. Now that ICMR is into rolling out national guidelines, if at all dengue is one of their interests, maybe this is a good venture to possibly look into it. Yeah. Meanwhile, I'm happy for any other audience also for their comments or questions, which we can have a discussion on.
So now we open the house to discussion. If anybody wants to ask any live questions, you can just put your hands up. Or you can even use the chat box. If you have any pressing doubts, we can have a discussion. So I had a doubt. So like when you discuss the systematic review, so you went through the set of questions for the critical appraisal. So especially I had a like how often do we get data from, you said, the gray literature? And second question is, how do we ask the experts? Because you mentioned they have not personally contacted the experts. So how do we decide on that? Because we get so many systematic reviews, and when we conduct also, we also have our own limitations, because certain databases, for example, I think Embase, we do not have access to. So in that case, how would you address such a limitation?
So like I had said that in the searching of the literature, they had not, in the systematic review, they had not looked at few evidence which is available, and there could be some potential studies there which could have been missed. So like this gray literature, so these are areas where which could also be searched actually, but we are not really sure about what is the quality of evidence we might get from any of these search strategies and all that. However, it is important when we are doing a systematic review to at least highlight that how many studies are actually coming out in the even smaller studies, even the results might not be statistically significant, or it might not be a big results or the number of studies, but we need all smaller and bigger studies to finally, when you conclude and form a guideline based evidence, that is really needed. So regarding this, contacting the experts in the field also, again, there were previous guidelines on dengue which is already available in WHO as well. So like recommendations which came out in 2018 as to use of the CYD TDV vaccine. So it was important, I felt, that before major evidence which is coming out as a systematic review, to contact experts that what is their evidence of using these vaccines and what else could have been included. So that is something which will actually increase the overall quality of the systematic review also, if they had done that. But I agree that the appraise and all that is paid platforms that you don't have access to that to look at those studies available. But they could have mentioned that in the article that they have tried looking through these sources also, and then probably they're not able to get. But it is important to mention that so that we also know that they have made an effort to actually find out all the information which is available regarding dengue vaccines.
If I could just add a point to what Dr. Elvin also mentioned, with regards to grey literature, there may be a lot of unpublished studies. One, it is possible in the context of very small or very sparsely funded trials, which may be of a very small scale, and they may not have got a publication domain for it to get published, either because it was small or it did not have a significant result. So it may amount to some publication bias. If we are having a tendency to avoid those literature, it is possible that the available published studies may overestimate the efficacy. So the presence of gray literature may probably give us a more conservative or something close to reality. That is one of our opinions. Second thing is, one way of searching it is to look at the clinical trials registry, and if anything is ongoing or unpublished, contact the authors through the email addresses and see whatever information that we get. And suppose many of the times we may not get a response, but it will be useful if we have the number of ongoing trials or the number of studies which are awaiting classification just for want of details. That by itself will give us some, because that publication, that will amount to publication bias, and if there is a good amount of publication bias, it will rate down the certainty of evidence. So finally, when we are grading the evidence, if there is a significant publication bias, it will a high quality. Even if there is a high quality evidence, it may become a moderate certainty evidence, which may once again have a great bearing in the strength of recommendation when it comes to a guideline. So that's and regarding experts, yes, I mean, it's not something which is formalized, but it may just be a casual, say, in case we meet like-minded people in a conference or in the setting of a get-together, as of today, similar to today. Suppose if we get one or two trials which we may have missed in our limited scoping search, it means that that's also considered as an expert, contacting expert in the field. So that has not been formalized, but even getting some just by way of casual talk or in the context of an academic meeting would be giving some useful information. I think that's why the experts in the field also is one of the criteria which has been mentioned in the abstract checklist.
Thank you, sir. There's one question. With outcomes as suggested by Delphi experts, there is no mention of serological response, which is the main outcome of the current trial. So what is the issue with serological response as an outcome?
With regards to this, one is the core outcome set has been designed pretty much with the patient preference in mind usually. So it also contains patient representative groups. So when they discuss with the patient representative groups as well, it appears that the patients have given more importance to clinical outcomes like their own well-being, when they are able to return to work, what has been their quality of life, how has it affected their livelihood or their mortality or survival, rather than the levels of the antibodies in their blood levels. So it appears that patients are more concerned about them. And as healthcare providers, I think we are also in need of doing something what is expected by the patients themselves. So if they do not value a serological response as a great response, then probably I'm not saying we should not be looking at serological outcomes, but patient-related outcomes are also something which ideally should also be looked into. Of course, there is a physiological response only based on which we also look at. They are basic sciences which we should know, but clinical decision making will have to be based on clinical response. So that's why this COMET initiative or this core outcome sets have been developed for various domains. So the COMET website is where we managed to get this reference from. So, so for clinical decision making, it appears that we have to take based on clinical outcomes which are preferred by patients.
One more question, sir. Given the
Yes.
potential for publication bias and selective reporting in clinical trials, how well do current systematic reviews address these issues? And should umbrella reviews place greater emphasis on evaluating meta biases?
Yes, that's a valid question. Yes, there is a potential for publication bias and selective reporting. One way how systematic reviews address is by comparing it with the protocol. So if in the trial protocol they have listed a few outcomes which are not reported finally in the trial in the main publication, then it would amount to selective reporting. So always the systematic reviewers will have to carefully look at the protocol plus the final manuscript to identify the same. Yes, umbrella reviews definitely. Yeah, that's a good thought, which I've not thought about. Yeah, probably. Yeah, thanks for that suggestion as well.
So how is that? Is it like a umbrella review, same as a scoping review, sir, or is it something different?
Umbrella review is sometimes considered as review of reviews. So we do a review of systematic reviews, and it's a broad term which will include multiple systematic reviews also underlying it.
So are there any further questions from the house? Okay. So there are no further questions. So thank you, Dr. Elvin, for that very comprehensive evidence synthesis on dengue vaccines. Thank you, Dr. Vignesh. It was an honor and privilege to have you chair this session, and we look forward to learn from you more as we go through this project. We probably have more of these evidence synthesis sessions coming up. So thank you all for attending. Our next session will be on the neurology of rabies, which is planned on April 8th. So kindly tune in for the same. Thank you.
Thank you. Thank you so much for the opportunity.